I know it's Friday afternoon, so I'm going to start on time and make sure we can get you guys home at a happy hour. Do you guys want me to start by going up over the quizzes? Would that be a good place to start?
Sure.
Okay. Now's the time I wish I had old school projectors. Let me see if I can hold this up on my computer for you guys. Instead of me just reading through them. Do you guys like the visual aspect, I'm assuming? Okay. There we go. So the first question, as I'm kind of going into this now, you guys will see it pop up on the screen in a second, I promise. Which of the following FDA-approved medications is indicated to treat insomnia that is associated with a feeling of next-day hangover? So the key to this question is that when you are thinking about which drugs and their half-lives, anything that has an intermediate half-life, okay, so when you're thinking about this, anything that has anticholinergic properties, or anything that has a half-life of 7 to 8 hours-ish or more. Okay, so especially your longer-acting benzos like your flurazepam, clozapam, midazolam, even intermediate-acting like temazepam, Klonopin, your longer-acting non-benzos, so your Z drugs, so your Lunesta, azopiclone, and zolpidem, Ambien. Those half-lives are longer, right? 6 to 8, 7 to 8 hours. So those are specifically, let me see if I can get this back up. There we go. Okay, so those specifically are the things you want to keep in mind. So the list was diphenhydramine and doxylamine. Remember, we talked about one of the problems with those drugs is besides the tolerance happens is that next day hangover feeling because of the anticholinergic properties to it. Flurazepam, again, long-acting. Remember that active metabolite, the N-disulfurrazepam, has about a 39-hour half-life, even though the parent drug is only 8 hours. Zaloplan Sonata, remember, that Z drug is great for about 3 hours and then it has no long-term residual effects. So that is very good in those patients that you are worried about that next day hangover, if it's just falling asleep, or if you want to have them sleep for just a 3-hour period and not have the drug having any residual effect. So that is not something I'm worried about with long term. Melteon, remember, acts like melatonin, good for inducing sleep, not necessarily making you groggy the next day, so no hangover with the Melteon. Doxepin is Cinequan, and I specifically made sure I put Cinequan. I did not put just doxepin, where you would dose it at an antidepressant dose of 25 or higher. Remember, we talked about dosage with doxepin has almost no side effects because that drug given at the average dose around 4 milligrams is generally easy to take, has pretty much none of the side effects we normally think about with a TCA. Okay, so that one is not associated with next day hangover, even though it does have antihistamine properties to it. Overall, patients don't look at that as having too many side effects across the board. Okay. So that wasn't meant to trip you up. I put Cinequan there. I deliberately put the brand names next to the drugs on this question so you guys would see Cinequan and hopefully remember that, okay? And then zolpidem, as I mentioned, your Lunesta and your Ambien. Zolpidem being listed there, you know that drug specifically has a half-life about 8 hours, so you can't have some next day hangover, okay? Is there questions on that? We good? Does it make sense on why those have a hangover effect? Yeah. Okay. Not loading up. I don't know if it's just the link is still loading up or what is going on. All right. Hopefully that'll pop up in a minute. I've been having issues where the microphone doesn't even work in here right now. So I saw IT, like literally he ran through in the middle of the quiz for the last section. I don't know what's going on. He didn't say anything I wish he would have. Sorry. After ruling out other comorbid medical conditions for RLS, restless leg syndrome, which of the following meds is best recommended to treat a patient with mild restless leg syndrome? Your key to this question is I highlighted and I bolded mild, not severe. Okay? So mild, most of the studies that have been done show that low-dose clonazepam, 0.5 milligrams, is what you would want to use for mild. If it said severe, that's when you're thinking your dopamine agonists, okay, like your ropenolol and Mirapex. Quinine sulfate used to be recommended for restless leg syndrome all the time. I did not mention it in my lecture, okay, because it is totally ineffective. They used to use that drug. I can tell you when I used to be a pharmacist, we would see that drug flying off the shelves for restless leg syndrome. It doesn't work. It is completely no efficacy. Oxycodone, we only use that if we absolutely have to because of the tolerance effect with that as well. But again, in comparison, it's not something we normally think of for mild RLS. It can be a little more severe if you're having to go to an opiate. And then, I guess I mentioned ropenolol. Ropenolol is for severe. Okay? We had an issue last year when I pressed picture mute. For some reason, it actually worked. So, it's not working. Okay. Then you had your true or false questions. Patients are at an increased risk for cardiac arrhythmias when they have obstructive sleep apnea. That is true. Nearly all patients with obstructive sleep apnea are overweight. That is false. Remember, 50% are overweight. That means 50% are not. That is not nearly all. Everybody always thinks of it as a disease of obesity. Not always the case. And clonazepam is safe to use in patients with OSA is false. You want to make sure you avoid any central nervous system depressants whenever possible in your OSA patients. Questions on those, you guys? You good? No? Yes.
Would it be possible for you to post these on Blackboard so we could have them to study with?
Yeah, I can do that.
Thank you.
Well,
You'll have to do it the
that
second.
kind of goes, well, I've been told I'm not supposed to give questions back.
Oh, yeah, that's
Personally, I like the fact that you guys can have them to study with, so I'll definitely post these for you. It's fine.
Thank you.
Mm-hmm. I can't release them to you on exam stuff. That's what I can't do, but I will at least post them in Blackboard.
Perfect. Thank you.
Okay, then you had to match the following presentations, symptom presentations to abnormal dopamine levels in the associated pathways. So when you think of auditory hallucinations, what pathway are you thinking about? Auditory hallucinations are happening because there's too much dopamine in what tract? Remember that mesolimbic, mesocortical, nigrostriatal, or tuberoinfundibular are your choices. So auditory hallucinations, where our drugs work to block, D2 is going to go block in what pathway? You guys, I guarantee you need to know your dopamine pathways. Mesolimbic, yes. Amenorrhea, which is due to prolactin increases, okay? What is prolactin associated with when dopamine is blocked there? Tuberoinfundibular, right. What about impaired executive function? You automatically think impaired executive function is cognitive, mesocortical. Remember the COs, right? Mesocortical, cognitive. And then dystonia. Dystonia is an extrapyramidal side effect associated with what pathway? Nigrostriatal, right. Okay? You guys are going to see those again in Parkinson's next year. You have to have an idea of those dopamine tracks to help make sense of your drugs. So there's reasons I want you guys to remember them. I promise it helps later on. All right. Which of the following typical antipsychotics has the lowest risk for causing anticholinergic side effects? So this kind of went to speak to that table where I have the arrow like this. Oh, that's a really bad arrow. Wow. Here's my arrow. Okay, so we had low EPS and high anticholinergic, and we had thorazine and equal to, like in terms of dosage, to Mellaril and all those thioridazine, right? We'll stick with the generics. Chlorpromazine and thioridazine, your ages. You guys can't see this anyways, can you?
Not very well.
Okay. I hate writing on the board. Hate it. So thorazine and thioridazine, remember 100 milligrams up top. Chlorpromazine, thioridazine. Thioridazine is the highest drug to cause anticholinergic effects. Okay. I told you guys if you picked thorazine on the exam, I wasn't trying to trip you up because I know they're equipotent, so I wouldn't mark you down for that. But the correct answer is thioridazine has the highest anticholinergic side effects. Period. That was like bright and bold in my slides. Okay. The lowest risk down here with your EPS, high EPS, low anticholinergic. And remember that I was talking to you guys about if you can see your drug and the receptor. This is Haldol. No other receptors on board. Okay? You start thinking of thorazine. Okay? Let's say this was thorazine. So if you're thinking thorazine, right? You're thinking it's got anticholinergic, antimuscarinic, all kinds of other receptors it hits on here. So it's a dirtier drug, right? Your key is the anticholinergic side effects that this drug will cause. So it almost has a built-in blocker against EPS. It's like almost like giving Haldol and Cogentin, or Haldol and Benadryl. So not 100%. You may still have to do that because you can still see EPS and thorazine, right? But less of a risk. Okay? All right. So that is why the answer to the lowest risk to cause anticholinergics was fluphenazine. Okay, fluphenazine and Haldol, remember, equipotent, low risk of anticholinergic. For those of you that had the test on the other day, I had highest risk for anticholinergic side effects, thorazine, or remember, or Mellaril, I said would be acceptable. Thioridazine is the highest. Okay. Next question was, there are 4 typical and 2 atypical antipsychotics available in long-acting dosage forms. Which of the following antipsychotics are available in long-acting dosage forms? So I gave you 10 drugs. It did not necessarily mean that all 6 of them were listed there, okay? Your 4 drugs that are atypicals are your Abilify, Maintena, right? Your Invega Sustenna, your Risperdal Consta, and your Zyprexa Relprevv. Okay? Your typicals are the 2 that I told you guys to remember dosing on, which I think everybody got them, which was Prolixin and Haldol. Okay? Those are the only ones. They're talking about maybe having a long-acting injectable down the line with Fanapt. Has not panned out at this point. All right, we had BG, who is a 36-year-old white female with schizophrenia for 3 years, whose only medication is Haldol, 10 milligrams twice a day. She's well stabilized on her meds. She's not tolerated dosage reductions in the past, and this choice was made due to her sister also having schizophrenia responding well to Haldol. That usually does happen within families. If it works for one sister, it might work for the other. Okay, so this is the physician's first choice, and she's never been on another med. She's noticing periods of bradykinesia, so slowed movement, and a shuffling gait. So pseudo-Parkinsonism, right? Look like Parkinsonian traits going on. Within 1 hour of taking Haldol, peak of the drug. Which of the following is an appropriate recommendation at this time? So initiate Cogentin. Anytime somebody's got EPS, you want to get that to go away as fast as possible. So yes, please start Cogentin. Taper off Haldol and initiate aripiprazole, 5 milligrams in the morning. That is also true. Why not try something that's atypical with less of a profile to cause EPS? And then taper off Haldol and initiate Thorazine. I'm not going to switch from a typical to a typical in someone that I already know is having EPS. It would be better to start her on an atypical agent that has less of a risk. Okay? Questions on that one? You guys good? All right. And true or false for each of the following statements regarding Latuda. So Latuda, give with caution in combination of highly protein-bound drugs. True or false? What do you guys think? True, right? Remember we said that it was over 99% protein bound? Remember I told you that it has a very similar profile to Geodon, right? So Geodon is another one, I think was on the other exam. Very similar, that drug you give in combination with highly protein bound drugs. You don't know where the levels are actually going to go because of the binding issues, okay? So you don't want to give it with highly protein bound drugs if possible. So that's true. Should be dosed daily in the morning due to its activating potential. I don't really care about the activating potential of Latuda. Not activating. We're thinking of what drug when we say it's activating. Abilify, right. Abilify. So that's false. Give with food to improve bioavailability.
Yes.
True. You want to give that drug with 350 calories or more. That is also true for Geodon. Geodon you also want to give with food. That's why because of the shorter half-life of that drug, we give it twice a day with meals. And with Geodon, it's more upsetting to the stomach, so that also helps when you give it with food. Okay? And then, not susceptible to enzyme-inducing drugs, carbamazepine. What is the primary metabolism of Latuda? And Geodon actually as well. 3A4. So you absolutely have to worry about carbamazepine on board with that. Okay? And then recommend baseline electrocardiogram due to QTC prolongation. True or false? For Latuda. False. Not really looking at that drug as a high risk. Now, if I were to have Geodon, Geodon is true. So if you had that version where it had Geodon, that is true. Okay? One of the differences there. The other drug that we worry about with QTC besides Geodon is having a high risk. So you're going to see a lot of your antipsychotics will pop up with an increased risk to cause QTC. Risperdal will even show up. But it's much smaller than what we look at for the 9 milliseconds seen with what other drug? Fanapt, iloperidone. Okay? So watch out for your elderly patients or those with cardiac arrhythmias because of those QTC issues. Always do baseline EKG and follow up. All right. The patient was taking haloperidol 10 milligrams twice a day, so 20 milligrams a day, and the physician wanted to convert them to Haldol-DEC. What would be the total DEC dosage and frequency you would recommend? So you're thinking conventional dosing, 4 weeks, right? Instantaneously, you can rule out the ones that said 2 weeks. And because you have 20 milligrams conventional dosing, 20 times 10 is what? 200 milligrams. 20 times 15 is 300 milligrams, right? So the only option that you had there was it is 200 milligrams every 4 weeks. Pretty straightforward. Okay? All right. All the following adverse effects are associated with clozapine except. So we have agranulocytosis. Does clozapine cause agranulocytosis? It's Friday afternoon, whatever. All of the following adverse effects are associated with clozapine except. So agranulocytosis,
Yes.
we definitely know you have to register patients in the Clozapine National Registry specifically because of agranulocytosis, right?
Mm-hmm.
No other reason is why they're in the CNR. Okay, diarrhea.
No.
Does not cause diarrhea. If anything, it causes
Constipation.
constipation. The fact that you want to make sure they maintain regular bowel movements because it can cause ischemic bowel, which will kill you. So make sure they have regular BMs. All right, hypersialuria definitely causes drooling, right? Extra salivation. The higher the dose, the worse that can get. We actually treat that with, sometimes you guys normally think of the inhaler Atrovent for COPD. but you use that under the tongue sometimes for clozapine because of the drooling can be so severe, and it helps dry up some of these secretions. Anticholinergics don't really help a whole lot with that at all, as much as people will kind of throw those on board as well. So dosage decreasing and Adjuvant under the tongue can sometimes be really helpful for the gross drooling that often accompanies Clozaril. Seizure, we know that it decreases seizure threshold. The higher the dose, the higher the risk. Remember the percentages on the slide, right? Keep that in mind. And then sudden cardiac death. So remember, clozapine is a funky drug. It definitely is known to cause sudden cardiac death. Interestingly enough, what they have found, if you can't remember, if you think about clozapine, they've shown that increased eosinophils, we're talking in the thousands. Normally we think of what with increased eosinophils? So you guys, when you took patho, you had some, I'm sure you had some mention of this. So normally high eosinophils, we think parasitic infections or allergies, right, due to inflammation. So they won't be showing any signs of parasitic infections, and they won't be showing any signs of like a severe allergy. But what will happen all of a sudden is they have a sudden cardiac death. So if you have somebody who's on clozapine and you do a CBC, you do want to take a look at those eosinophils. That has some causal linkage. They're not 100% sure if it's just the eosinophils or not, but okay. I think I just want to check the other version of the exam. I covered both. Just want to make sure I didn't miss anything here. Okay, so same thing. Temazepam, I think I changed the drug to temazepam is safe with OSA. Obviously, again, any CNS depressant, not good for obstructive sleep apnea. I said half of the patients with OSA are overweight. That would be true. And patients are at an increased risk for cardiac arrhythmia is true. We already talked about the high risk for anticholinergic. So yeah, it's Ziprasidone again. Give with caution in highly protein-bound drugs. Give with food to improve bioavailability. And recommend baseline in follow-up EKG due to potential QTC are all true. It is not true that it should be dosed daily in the morning due to its activating potential. You want to dose that drug twice a day. And it is definitely susceptible to enzyme-inducing drugs. So the fact that it says it's not susceptible, you know that's false. And then I had you guys look at flufenazine, 10 milligrams twice a day. So flufenazine, 10 milligrams twice a day is a total daily dose of 20 milligrams, right? So if you were to convert that, 1.25 times 10 comes out to 25 milligrams, and you give flufenazine every 2 to 3 weeks. So A would be the answer there where it said 25 milligrams every 2 weeks. You guys okay in understanding on why that is the answer? 1.25 times your total daily dosage, given every 2 to 3 weeks is your conventional dosing for Elixin. Okay. Do you guys still have questions on the deck dosing? Do you want me to go over that? Are you okay? You guys okay? Does anybody want me to go over it? I don't mind. Go over it? Okay. So rule of thumb is Prolixin you want to remember total dose, total daily dose, times 1.25. So if you look in the book, if you look in the book, or you look in Micromedics or Lexicomp, it'll tell you 12.5 milligrams of the decanoate is equal to 10 milligrams of your oral. This is where that 1.25 is. I converted it for you on your slide, so you don't have to worry about the Stimmel method, which is 1.2 up to 1.6. And depending on which method you look at, if you look in the book or you look online in Lexicomp or Micromedics, it gets confusing, okay? Try to boil it down and simplify it for you guys to remember. Stimmel method is 1.2 up to 1.6 in severe patients, and it says that you give it every week for 4 to 6 weeks, and it gets really confusing. I don't care if you know about that or not. The easy way to dose it is the way that most clinicians think about it, is you give the drug you're going to give the drug, whatever the daily dose is. So say they're on 10 milligrams, that would be 12.5 milligrams, right? 10 times 1.25 equals 12.5. So you give the drug, dose 1, dose 2, 12.5 milligrams, oral supplementation until dose 2. Okay? So the same is true for Haldol conventional dosing as it is for Prolixin, and then you're going to give this every, again, 2 to 3 weeks after that first dose. So this is 1 week. Okay? So dose 1, a week later, I give dose 2, and forever thereafter, every 2 to 3 weeks is the easiest way to remember it. Okay? I orally supplement with my 10 milligrams, right? For 1 week. Once I give the second injection, I don't have to orally supplement anymore. It's basically just make sure you have enough in their system that, you know, if you just give the one dosage because of the release of the drug, it's going to take a little while for it to get to a steady state. So by the second injection that's getting added on, you don't have to orally supplement. So the same concept holds through with Haldol between the conventional dosing from first to second. So if we were talking about Haldol, so this is Prolixin, right? Okay, I wish I had another color, but this is kind of get a fabulous word, sorry. We were talking of Haldol, okay? You've got your total daily dose, we just call that TDD for now, total daily dose, times 10 to 15, right? Okay? So same concept. If I'm giving 10 milligrams as a total daily dose, that means my conventional dose for dose 1 is going to be, what? 10 times 10 is 100 to 150, right? So unfortunately, they give a range for Haldol. So you've got 100 to 150. Let's say the doctor just picked 100, okay? That's dose 1. And then dose 2, same thing. And this is going to be a month later, so 4 weeks. Okay, dose 2. And then you're going to give another 100 milligrams. Okay? Now, that's for your conventional dosing, right? So you also, if you do that, you're going to have to give your oral 10 milligrams until your second dose, and then you stop it. Okay? So anytime you give the second dose, you can stop your oral supplementation. All right? Now, the fact is if you don't want to orally supplement with Haldol, Larry Arashevsky, that really cool pharmacist down in Texas, decided that he, did a study on this and showed that instead of doing oral supplementation for that month, you can double what you would here. So loading dose is times 20, okay? And that's just so you don't have to orally supplement. After that one dosage of the load, you stop giving oral, and you don't ever have to worry about this side of it at all, okay? This is gone with the loading dose. Loading dose, don't worry about oral, okay? So the idea is that you give it, so 10 times 20, my daily dose was 20, that is a total loading dose of 200 milligrams. So remember, rule of thumb, no matter what your total dose comes out to, that initial one-time injection, you have to give 100 milligrams, okay? And then you give the remainder of it. So since it's 200 milligrams, if it was 100, right? Then that would be another 100 milligrams 3 to 7 days later, and then you don't have to orally supplement, okay? So your load dose, 200 milligrams, you give 100 milligrams following 3 to 7 days later, you give the remainder. You're done with oral supplementation. And then the next month, again, because loading dose is just the initial load, you don't keep it at the loading dose. That's just the one time since you don't want to orally supplement. You go back to this. You go back to your what it would be for your conventional dosing the second month out, or even your first few stuck with conventional. Does that make sense? Yes.
So the loading dose one from day 1 to 3 to 7 days, you give oral or you don't give
No, you don't have to, because your plan is like you're switching completely over to injection. So you give the 100 and then you give the next 100 3 to 7 days later. And I will tell you, it is just because of the initial injection, especially that you do that. So if I had a patient, for example, I've had patients that have come on and have been on Haldol Deck before and then haven't been on it for a while. I can start them out just right at their 200, at a 200 milligram dose potentially there. It's just to test it's because of the sensitivity. You don't want to give more than that because they found reactions that have happened. So if a person is naive to Haldol, no matter what, you give a max of 100 and then the remainder 3 to 7 days later. That goes for conventional or below. Okay? Is that clear? Did that help at all, or you guys still lost?
For the loading dose, so when you give the loading dose, you're not giving the 100 dose anymore. Like so, because you do the 100 milligram dose, the 150 milligram dose for the first one, and then 4 weeks later you do the other one for dose 2.
Right.
And you would give the oral. But since you're excluding the oral, you're just giving the total 200 milligram dose over the 3 to 4 days, and so that's it. Ultimately, it's just 200. It's not like that 200 plus the 100 loading first dose, right?
Exactly. Yeah. So you're just giving.
It's like that takes over as your first dose.
It takes over as your first dose.
Okay.
Yeah. So you don't have to supplement any oral.
Right.
Exactly.
So it's not
that's
like
the
the
whole
100
point.
milligrams plus another 100 milligrams for the loading dose. Or, no, it's just.
No,
okay.
it's just you take your total load dose
Right.
and then give 100 plus up to another.
100.
So yeah. So.
Okay.
No matter what, you never give more than the max of
Right.
450,
Okay.
and you never give more than 100 for the initial injection. But it all adds up to your total, either load or conventional dose. Is that clear?
Yeah.
Okay. All right, you guys good on this? Oh, yes.
So after you're done with the loading dose, then you go to 100?
Yeah. So you always need to calculate your conventional to know your regular every 4-week dosage.
Oh, okay.
Okay? But if you don't want to orally supplement, that's when you come in and double it pretty much with your load, right? So you don't have to give the oral for that 4 weeks. That's why they do that. Okay? Yes?
I'm confused on the brand name for doxepin. So the one that's like the antidepressant TCA, is that Cinequan?
No. Cinequan is approved as the insomnia.
So this slide says Selenor, a path to more sleep.
Alright, so yes, Cinequan. Okay. Selenor, yes. Yes, yes. Cinequan is actually the TCA. So I
Spelled it better.
Oh, look at this. If I did, you guys would credit for that. So yeah, I screwed up on here. I put Cinequan,
Which is for
which
the
is the
antidepressant.
TCA
Yeah,
for
exactly.
depression.
Yeah.
Yes. So that one. Okay. So yeah. So Cinequan would actually have. Oh, you know what? I did that on purpose too. On the back. Okay. So yeah, Cinequan is your TCA if you were using that for sleep. I won't count that against you guys. I wasn't trying to confuse you. Cinequan is your depression version. Selenor is your insomnia approved drug. Okay. So I'll make sure that that's graded correctly when I post the grades this weekend. Okay. Okay. Other questions about that quiz? You guys good?
Mm-hmm.
All right. Looking at do you guys want to talk about schizophrenia first, then that it's on your mind, and the sleep stuff, or do you want me to go right into the bipolar quiz?
Schizophrenia.
Schizophrenia? You guys want to talk about, well, since we're kind of in schizophrenia track right now?
Yeah.
Okay. So, do you guys have questions you want me to answer at this point that are still kind of bothering you that I can go over about anything on the couple lectures and case day we had? No?
What should we focus on?
Do a focus review?
Please.
Okay. All right. Let me put my notes up front so you guys your focus points. Okay. All right, so overall I would, hold on, this is the wrong There we go. Okay. So when all right. So when you're looking at that first lecture, we spent a lot of time. Again, you need to know your dopamine tracks. So you have an idea when you're talking about drugs and their side effects. It really does help as a whole if you have an idea of which ones are involved and how those work. So they were on the quiz. I told you guys several times over, I promise you need to know your dopamine tracks and what's associated with them, okay? Let's see. This is taking so long to go from page to page. Okay. When you are looking at your diagnostic criteria, have an idea. Actually, you guys want me to start with sleep? That would probably make more sense because that's the first module in the exam.
Sure.
Is that okay?
Yeah.
Sleep works? Okay.
Yeah.
So, sleep stage, I want you guys to have an idea of when you normally see abnormalities. So, if I were to talk to you about, REM sleep versus non-REM sleep and your 4 sleep stages, if you were having somebody who typically has a REM sleep disorder versus like a parasomnia, like sleepwalking or bedwetting, what stages do those typically happen in? Okay. When you are looking at your drugs, I mentioned a couple drugs that affect the sleep cycle, right? So we know like benzodiazepines, for example, have direct effects on the sleep cycle, where our newer Z drugs, specifically, we talked about them not having an effect on the sleep cycle. So that's part of the reason why they're more preferred agents now for insomnia, right? So you're going to want to know which ones have those effects. We talked about briefly, phenobarbital, chloral hydrate not being preferred options. Like, know why that those are not preferred options anymore. Okay. Have an idea with those drugs that are approved and not approved to treat insomnia. Okay. There's a lot of off-labels. We specifically talked about a few options. For example, we talked about the doxepin low dose, the Silanor. We talked about, amitriptyline and, imipramine, even, some of those TCAs are pretty sedative, but you don't really see those FDA recommended specifically for insomnia. If somebody has a particular type of insomnia, we talked about like benzodiazepines being really good to help overall a person feel like they're rested and have slept, right? So, sleep stage misperception, benzodiazepines can be good for that versus somebody who's got antidepressant-induced insomnia or depression-related insomnia. We talked about which drugs are good for that. So that's where your like trazodone and your mirtazapine kind of come into play. You want to have an idea in terms of like the mechanisms of action of how they're working. So like your melatonin drugs are good to help you kind of fall asleep, but aren't necessarily going to help maintain you through sleep. Versus your Z drugs, knowing that like Sonata has a shorter half-life, Ambien and Len has to have a little bit longer. So depending on what type of sleep issues you're having, you are going to have some superiority there. Your intermediate acting drugs like Klonopin, temazepam, temazepam again being the one that's FDA approved, is more the one you're going to see recommended, knowing the issues that are associated with them. So if you take those drugs and you have your patient complaining they don't fall asleep right away, well, remember some of the pharmacokinetic variables. A benzo is a benzo is a benzo is a benzo, right? You know the differences because of their pharmacokinetics. So know what those differences are for the ones that are approved. Already talked about some of this stuff already. My notes here. Talked about the drugs that have hangover effects already. We talked about the quiz. When we're looking at treating, slides up here too. When we're looking at treating narcolepsy, know which medications are recommended in treating narcolepsy. There's not a ridiculous robust amount of them, but you know when we're looking at stimulants, when you're looking at sodium oxybate, like what do they treat best? We talked a little bit about on the quiz already. What is approved to treat restless leg? You want to know what's appropriate for mild. You want to know what's appropriate for severe. You want to know your basic causes for causing restless leg. So you know things like anemia, pregnancy, the stuff that we went over. Know what your causes of restless leg are. Okay, so we also went over. I'm just going to go through the slides really quick and the ones that I marked highlighted for you guys to know. I just want to make sure I'm not forgetting anything. Help you out with your focus. Let's see. Okay, covered all that stuff first. Oh yeah, so when we did talk about, remember those common etiologies of insomnia too, like which drugs we talked about are better choices for those. Kind of alluded to that a little already, but make sure you're comfortable with that. And your herbal products, the valerian root and melatonin, we talked about when they're most appropriate, like I said. Know your durations of your drug's efficacy. So again, we already said that, like the Zalopon being shorter acting, your other Z drugs a little longer acting. So Ambien 6 to 8 hours, your Vanessa 7 to 8. I'll kind of go into that hangover question I asked. And about it for sleep disorders, I think. Do you guys have any other questions regarding sleep disorders? No? Easy peasy? Everybody's gonna knock that out without any problem, I hope. Okay. Know your side effects for your drugs that we talked about that I made a point to say in class. So, for example, we're talking about, you know, like a reason that people discontinue Lunesta, for example, because of the metallic taste, or if we're talking about dopamine agonists, and we talked about people having an issue starting to take it with like nausea and vomiting, the sleep attacks that kind of are a serious side effect afterward about driving and having a sleep attack and falling asleep at the wheel. So those are kind of like the few that I want to try and pay attention to. There's only a couple drug therapies for obstructive sleep apnea. Just making sure more so than anything you avoid your CNS depressants, and you really, the couple options. More of your activating antidepressants, particularly Prozac, shown to reduce apnea. As Protriptyline has been shown to help out with mild apnea. So straight from the slide there. Not a ton of drug stuff to know. Okay. So moving on to schizophrenia. All right. Okay, so within the schizophrenia slides, I'm not expecting you guys, and I kind of put it in one of the responses to the discussion board, but I'm not going to expect you to go and like memorize when Eugene Bleuler, was alive, those types of questions. I'm not going to do that. It was really as a historical idea to get you to start thinking about where schizophrenia has been and where it's kind of going. Having an idea of the etiology and pathophysiology, like your patients overall, what's associated with abnormalities. So, we've seen that schizophrenic patients clearly have a decreased overall brain size, things like their increased ventricular size and the third and lateral ventricles. So clear, what you're seeing there is your clean and clear brain changes that are associated with schizophrenic patients, okay? So those, yeah, patho. The dopaminergic tracks, like I said, you've got a lot, and when we're talking about the pathophysiology, it's good to have an understanding of all those that are going on, so how the drugs work, but I spent a lot of time on the dopamine pathways. So, if you haven't already picked up me up saying that, know those. You should have a basic understanding of what phase of schizophrenia someone's in. So if I tell you that they, are you're noticing that a person is becoming disheveled, isolative, kind of, having some asociality to them, the function as a whole that's showing deterioration, that prodromal phase versus the active phase when you're seeing the positive symptoms versus the negative symptoms alone. Those negative symptoms might be there before you start seeing hallucinations, delusions, disorganized speech, and behavior that is your active phase. I really want this projector to work. It would make our lives so much easier. I won't even show up with the code.
Is anybody upstairs?
I asked for Hannaford and they told me that it was booked, but
We just went by.
You guys are out there?
There wasn't anybody in there.
okay. Are you guys okay with me going through it like this, or do you really want the slides up?
It's fine.
You guys are okay?
Yeah.
Okay. And if you guys really, if it's helpful, I don't mind if you want to pop up there and I can go through them up there if you're up to it. I'm good at that. I want you guys to feel comfortable walking out of here. You know where to put your efforts. Okay. So yeah, know what your positive and negative symptoms are. I mean, you kind of have to know those when a person is presenting to know the phases, really. Your basic scales that are used would be helpful to know. So, I want you guys to, at least when you go into APPEs and you look at the literature, to not look puzzled and confused when somebody says a PAN score, your positive and negative syndrome scale, versus your BPRS, brief psychiatric rating scale, versus your cognitive scales, your mini mental status exam. We're actually going to do those on each other in patient assessment. So. It does help with your cognitive testing. Okay, and then getting into have an idea of what drugs or diseases can actually cause psychosis. You'll notice there's a lot of overlap here from schizophrenia and bipolar, and I spent time in both classes to go over those. Okay, so make sure you have an idea of those more stimulating drugs that are prone to cause psychosis, like your corticosteroids, your stimulants, your xanthines, anything dopaminergic. So your dopaminergic drugs that we sometimes even use for RLS, like propranolol or pramipexole or levodopa. Anything that's a hallucinogen can cause hallucinations, right? So LSD, PCP, the slides that kind of went over that are going to be important. Neurosyphilis, infections, cancer, meningitis, all those things. So those shouldn't be like a surprise that you see them in schizophrenia and in bipolar. Okay, talking about our drugs a little more, I really do need you guys to feel comfortable on when you start treating with a drug, when you expect to see a response. Okay? So the relative response to meds. It's going to be really important when you're looking at a patient walking through the door to not expect them necessarily to be completely psychosis-free within a day or two. In schizophrenia especially. You can see that in bipolar within a very short period of time, right? When we're talking about the antipsychotics, can work within 3 days. So not true in schizophrenia. You're usually looking at like 1 to 2 weeks to start hitting those positive symptoms. Pharmacotherapy for your typicals, we kind of went over, know which ones are higher risk for causing EPS or anticholinergic side effects. Know what your Parkinson's symptoms are and how to treat them, right? So we went over EPS, we went over acute dystonia, we went over pseudoparkinsonism, we went over akathisia, and we went over tardive dyskinesia, and we went over meds to treat them. If you are going to be treating anybody with antipsychotics, you have to know what drugs are going to reverse the side effects when they happen, if you can reverse them. So that's something I guarantee you want to be comfortable with.
So if somebody's presenting with akathisia, could you give them the antipsychotic as well as like lorazepam or benzo to?
So if somebody's having specifically just akathisia, a benzo won't always help as much as propranolol would.
Oh.
So propranolol is your go-to drug. If you were to say, they seem really anxious, the feeling that they're having is not, the ants in your pants feeling might make them feel like they're having anxiety. But usually if you directly treat the akathisia with propranolol and dose reduce, that's what you're going to target. So I'm not going to say you'd be inappropriate to give somebody who's that agitated from the akathisia something to calm down, but you're not treating a real disease. So lorazepam would not be a correct answer if I were to say give me the most appropriate option to treat akathisia. Okay? Yep. Okay. All right, so I'll do a real quick snapshot for your drugs on side effects to kind of hold on to. Your typicals as a class, there is a slide that specifically looks at adverse effects as a class, right? The ones that have a narrow therapeutic index or that I'm associated with certain side effects. I mentioned EPS, I mentioned anticholinergic. You want to remember which ones are associated with something like pigmentary retinopathy, especially with the max dose, with like thyroidazine. So have an idea of your class effect. So if I were to ask, which of the following medications cause prolactin increase, I don't want you just to think of Risperdal because it's more prone to the atypicals. Your typicals cause it just as much, if not more so, right? So as a class, they all can increase prolactin. Your high potency drugs that are known to cause neuromuscular, NMS is your neuroleptic malignant syndrome. You want to remember your high potency drugs are more likely to cause that, so your typicals are more likely to cause that, and your atypicals, though they all have the risk of causing it, and higher potency, higher risk. Treated really easily, I wouldn't say treated easily, treated very much in association with the literature out there recommending bromocriptine and dantrolene, but any dopamine agonist would be appropriate in that situation. So if you can get a dopamine agonist into them, that's what you're going to do. And actually, somebody in your class had mentioned to me that they hadn't seen bromocriptine. It is actually an oral. And I went back and I looked at that because any of the patients that have had that obviously cannot eat, and they get a tube put in for feedings. So you basically would just take the oral drug and you put it into the tube, and that's how you would get them dosed. So you would either do nasogastric tube or however you could get into the system, but it's not available IV. So, all right, let's see. Talked about the black box warnings. So if a drug has a black box warnings, know which drugs have a black box warnings, okay? So something like the pigmentary retinopathy I already mentioned, something like Zyprexa in children and adolescents has a higher risk for causing weight gain and hyperlipidemia. That's worth knowing, okay? I'm going through all these individually. Of your drugs, if you can kind of keep in mind like which drugs are more prone to cause side effects. So like if I have somebody who has EPS on Haldol, for example, okay, what is my option if I have a patient that says I absolutely want to prevent having EPS again? Give me the best option for my drugs. So you know your atypicals as a class have a lower risk, but there's also, we went over in class the dopamine blockade and which ones generally never have EPS occur, right? So you guys remember any of that? Clozapine and Seroquel, right, are your lowest risk. And then you kind of have others in a dose-dependent fashion that kind of fall in, where again, Risperdal and you know, like Fanapt, if you look at dopamine receptor blockade, they have a little bit higher risk of causing that, which is why you see more EPS and prolactin increases in those drugs as well. Remember Abilify akathisia. Remember your clozapine side effects for the ones that can generally kill you, the ones that are highlighted, keep an eye on. Okay, so you know, weight gain, the diabetes risk of hyperglycemia, the drooling, the hypersiuria, sudden cardiac death, GI complications, your adrenomyocytosis, and your seizure risk. It's got a lot more than that, but those are the big ones that'll kill you. Clozapine is one of the few drugs that actually has 5 black box warnings on it. Okay? 5. That's crazy. You know, Fanapt I mentioned again already, that the prolactin increases, orthostatic hypotension, QTC issues, kind of stuff we already mentioned with the quiz. I don't want to like beat a dead horse. I'm going to say it over and over again. Let's see. I think I'm forgetting anything else here. About Zyprexa. Remember the drugs that have a primary metabolism through one CYP isoenzyme. Know what those are. I don't care if it has 2 because I'm not really worried about it for drug interactions. You guys are pharmacists. If no one else knows these drug interactions, you should. Okay. So something like a Zyprexa being metabolized through 1A2, an interaction with that would be a problem. You know, when we're talking about Latuda, or we're talking about Geodon and 3A4 as examples, right? Seroquel, 3A4 as an issue, right? So those ones that have big CYPs, issues, you guys, again, you're going to know those where the doctors a lot of the time are not, and you're going to help them pick up on that. We talked about the long-actings, and I think that's it for schizophrenia, for what I have for you guys.
Dr. Sherwood.
Yeah.
For a drug, if it were to have multiple CYPs, this really isn't for anything, but like, so if it was say metabolized by CYP3A4 and by CYP1A2, is that better because then if CYP3A4 goes down, then it has a backup?
Exactly. Yep. I mean, there are times that if it's 3A4 and 1A2 and you have a drug like carbamazepine on board that's a heavy inducer of both, or you're still probably going to have a problem. And you'll still see drugs with 2 metabolites, like, you know, if they're on something like ketoconazole, which is going to inhibit it, that's going to be a problem, right? But, you know, unless I pointed it out, like I'll give you an example, like Romeldion, right? We have to worry about the 1A2 issue. Don't normally think about a lot of the drugs interacting with that, but they specifically say, even if you heard the commercial a couple years ago, they specifically say, watch out for Luvox with this drug because or Luvox and other strong CYP1A2 inhibitors. They actually did testing specifically on that and shows it can double the concentration of the drug. So, yeah, it's those ones, if it's primarily one metabolite through that isoenzyme, then you're going to have a problem if you have something blocking it. With 2, you do have that luxury of the other one kind of compensating a little bit. Okay. Any other questions on schizophrenia? You guys good on that side with the slides? I'm going to go through one more thing and make sure I didn't miss anything. The exam here. We talked about the skills. the exam. I really do make sure that my objectives link to all of my exam questions, so I'm going through that and making sure I didn't miss anything for you guys. Okay, I think that's about it for schizophrenia. Going into bipolar, which just so you guys are aware too, I go through the exam for the amount of time spent in lecture will equal the amount of questions on the exam. So I need to actually go and I'll double check this. I can tell you how many questions are in each. We had so roughly there's about 8 questions per lecture. And I can go back in the exam in a minute if you guys want. I'll take a look at that. But it's roughly like you roughly have 8 questions for sleep disorders, 16 questions for schizophrenia, and 24 questions for bipolar. I forget where I threw the extra one in because that comes out, or 1 or 2 in because that comes out to 48, I believe. So, sleep disorders, I can't remember if there's 8 or 9 there. I'll go back in and I'll take a look for you guys. Okay, and then, let's see, bipolar, I'm pulling out everything up again on bipolar. Almost there. Do you guys have any questions before I just kind of jump in with the focus points on bipolar? Do you want me to cover as I'm loading all this? Yes?
One of my questions was, I don't know if you were talking about when you referred to in slides the rapid medication discontinuation versus after remission, because for rapid medication discontinuation, it says meds should be tapered over 2 to 4 weeks, and then after remission, adjunctive agents are tapered and discontinued over 2 to 6 months.
Right.
So is that just like emergency situation where you have to discontinue the medication for everyone, or?
Yeah, so, well, it kind of comes in where, say I have a patient who has an issue with substance abuse, specifically like alcohol or benzos. If I have somebody who is on an adjunctive agent, started out when they're manic, for example, and I'm going to start them on a benzo as an adjunctive agent, that might be a population I don't really want to see go home with a benzo, right? So that would be a situation that within 2 to 4 weeks, I would get rid of it. If somebody doesn't have an issue with substance abuse, I'm going to be a little more lax about that, but that would be like a good example of when I would make sure it was much more rapid. So bare minimum, you never want to stop any medication in a bipolar patient that can be for mood in less than 2 to 4 weeks. Okay, so if it was a benzo situation, I would take usually that 2-week period and just make sure I've got them on a taper down on that so they don't continue on that. Especially because you don't want a benzo on board long term anyways, if they have especially a flipper quick. A quick flip to the depressive side, okay? If I were to have somebody augmented with, say, they were on lithium and risperidol that was started to help out with the psychotic piece, remember that's got some mood stabilizing components, but the idea is that we still would like to get our pill burden down, so that is when you're looking at a few months out and tapering down something like your adjunctive risperidol if you really just wanted to maintain them on lithium, okay? There's going to be patients that are going to end up staying on both the antipsychotic mood stabilizer and like your base mood stabilizer, like your lithium and your 3 approved anticonvulsants, maybe even like a trileptal kind of comes in there. We talked about that. But your overall, when you're thinking about augmentation therapy, anything that's added on specifically to treat an acute period, that's where that comes in. So, yeah. Never, never, never just cold turkey stop the drug. If you have to, that's where your 2 to 4 weeks comes in. Okay?
Except in toxicity.
Except in toxicity.
Okay.
Yes, you don't want to taper somebody off of lithium after they've just killed their kidneys with an overdosage, like our patient in the case. Okay. The following is This is not what I want. So my bipolar slides. There we go. Okay, so when we're looking at bipolar, we spent enough time where we kind of went through the difference between bipolar 1, bipolar 2, what rapid cycling means, what a mixed presentation is. People usually are going to start out in a depressed state and move in. Females are more likely to be diagnosed with certain types of bipolar than men, right? So in bipolar 1, it's pretty much equal to bipolar 2. I'm sorry, in bipolar 1, men and women are equal. I can't talk anymore, guys, I'm sorry. Men and women in bipolar 2, in terms of the diagnosis, is about equal. If you're talking bipolar 2, you're looking at women being more common than men, and rapid cyclers being women more common than men that are affected with that. You know that you have to have, a manic episode to equal bipolar 1, hypomanic to equal bipolar 2. Not really surprised, I hope. We've talked about that at length. Knowing that some of the other comorbidities that are common would be good to know, right? So substance abuse issues, suicide being a concern. When we look at initial presentation, I kind of already said when we start with depression and those types of things. Have an idea what induces certain episodes. So if we're talking about drugs, I already mentioned with schizophrenia, hallucinogens, stimulants, specifically calcium replacement, you can end up causing somebody to go into a mania with big doses of calcium. Hyperthyroidism causes what versus hypothyroidism. Sleep deprivation causes mania, which the mania causes sleep deprivation, but know that they fuel each other. Things like just the obvious things that can predispose you to having a cycle into one or the other episodes. We talked about that a lot in class, and we talked about it a lot during the case. If the quiz wasn't any clue, you need to know your plasma levels. Okay? I know that you guys have a lot of drugs, and everyone's like, which ones do I really need to know for doses? Well, if I'm highlighting in pink for plasma, right? Know what those are, have an idea of your general range for whether it's maintenance versus acute, if there's differences. We spent almost an entire class on lithium, so really know that drug for the side effects, know what to expect. You've got to be comfortable with the lithium slides. If we're thinking about people who become hypersexual on the hypomanic or manic side of the disorder, you want to remember to keep in mind in your female patients especially which ones are preferred for if they end up becoming pregnant, and what the risks are if they do become pregnant and are on them. If something is a category D or an X, you need to know what those issues are, okay? What's the first thing that pops in your mind when I say lamictal?
Stevens-Johnson syndrome.
Stevens-Johnson syndrome, yay! Okay. Woo. So, remember what you need to be on the lookout for with that drug in particular. Know which drugs cause the induction issues, or, like your enzyme-inducing anti-epileptic drugs that we went over versus valproic acid. Anytime you go up on the dose too quickly, you have to worry about what? 4-letter word, side effect? Rash, yes. So know that if you take the drug and you have a rash, you have to stop it, period. You don't start it again. Have an idea of what labs you should draw for what drugs. So like when we talked about obviously lithium, you want to think of a couple key monitoring parameters. So if you know your side effects, this gets a lot easier for labs. So we know lithium causes hypothyroidism. You're going to want to draw a thyroid panel. We know that it can cause abnormalities in the heart, so you want to do an EKG. You want to know that it causes kidney issues, so you're going to monitor things like sodium would be important to know, like if you're having somebody come in with signs of toxicity on are they dehydrated? Serum creatinine for the kidneys, BUN for the kidneys. When I pointed out in class today, make sure you don't say bun. Not picking on the student that said it, but I know I've heard many of you guys say bun. You're going to make your instructors go nuts. Dorn Blazer threw a fit about it in class one day because somebody said it. So, BUN, blood, urea, nitrogen, BUN, don't say bun. All right, I'm trying to think. Anything else on this? Some major points I wanted to make. I really tried to give you guys a clue on if somebody is a rapid cycler versus a mixed presentation versus your average, I shouldn't say average diagnosis, but your diagnosis of bipolar 1 or bipolar 2 without those mixed or rapid cycling presentations. Like, have an idea of what your first line therapies are for what is being presented with, okay? Your higher risk versus lower risk antidepressants to use in a patient who is bipolar. Generally know that we don't like to always use them, but if we do, what drug emerges as superior? You guys are thinking what? Hopefully. What drug is preferred when we look at the mechanism of action? It makes sense a little bit that it's not serotonergic. Bupropion, right? Wellbutrin. Same as we talked about with lithium, with divalproic sodium, with carbamazepine, with lamictal, know what issues you can have on the liver. Know what other side effects they've got, like when we talked about trileptal, I mentioned to you guys that has more hyponatremia, but carbamazepine, lower risk, but also causes that, your aplastic anemia, those types of things that come up as severe. If it was highlighted in my slide, if it's highlighted, that's like, I go back and I deliberately put things in another color to make sure that you guys are aware it's an important point. So I'm not going to say the entire exam is everything highlighted, right? But it is something that I want you guys to obviously key into when you think of treating a bipolar patient. So those key side effects that we went over, make sure you're comfortable with them, okay? And then if there are strategies, the same as when we talked about EPS and treating with an anticholinergic or dose-reducing certain strategies, we talked about what you can do if you have side effects of some of these drugs as well. So, something as simple as taking them with food, doesn't matter. Can you give a drug, once a day versus do you dose it a couple times a day because of half-life or, or because the GI upset, do you dose it a couple times a day? Those types of questions are going to be something in any patient that they walk in your pharmacy you're going to have to know. So keep those in mind. If there were strategies we talked about, have an idea what those are. Okay, and then I'm trying to think, what's the majority? We did talk about, I would say the same thing I talked about for schizophrenia. So response times, what you would expect to see. So I know we talked about our antipsychotics. Obviously, can have a lot more effect faster on the psychosis piece versus maintenance. We talked about your lithium, your lamotrigine, your Depakote, your carbamazepine, when they're most appropriate to use in which type of patients. Not to say that you can't, again, use any of the others as monotherapy, but keeping in mind what the best option is according to the evidence is where your first line therapies should be recommended. Questions on anything? You guys good? Yes, yes, yes. Okay. Know your drug interactions with these drugs as well. You know, if you've got something that's a narrow therapeutic drug, and it's easy to pick on lithium. So if you've got something that's like a narrow therapeutic drug and they're taking something as simple as an NSAID for a headache, you have to know that that could potentially spike their level, okay? Know your drug interactions. I promise you, if you look at your drug interactions, they won't be in vain, okay? I want you guys are the drug experts. Your PK issues with the drugs, specifically drug disease, are something that you need to know. Strategies to help in working toxicity. Okay, I think that's the majority of it. I'm just going to go through my second slides here to make sure. Go through my slides one more time. I think that should cover it. Looking at meds one more time. Pearls. That should be it. You guys have other questions that I can answer? Yes.
So for bipolar, first line should be thinking lithium, carbamazepine, Depakote, Lamictal.
For maintenance therapy, yes.
For maintenance therapy.
And you can start, obviously you're still going to start them when they're acute. They will help, they're
Right.
approved for acute, but they can take 1 to 3 weeks
Right.
overall when you're talking about the liver.
Because the book said, or I think it was in the book, some of the atypicals are also approved as first line therapy.
They
But
are.
really what I'm getting out of your lectures and stuff is you really want to look at those big ones first to see if those are
They are
acceptable.
FDA approved as monotherapy. The reason I say that, and again, you can definitely recommend them and try them as a monotherapy. So if I have somebody that comes in and, you know, I want to try Risperdal and I don't necessarily want to try polypharmacy, you can absolutely do that. The rule of thumb is if you look at efficacy overall, you're not going to find something in like bipolar 1 that's going to generally beat the lithium. Okay, if you look at, you know, overall efficacy, lithium, carbamazepine, and Depakote have got the numbers behind them to support them as your first line. I'm not going to say that, you know, quetiapine isn't considered a first line option.
Yep.
It is, but if you're looking at like efficacy,
Okay,
they've got a little bit better numbers behind them. That's why I say that.
perfect.
So you are correct in saying that they are recommended and FDA approved as monotherapy and listed as a first line agent. They are.
Right.
Those come strictly from your evidence-based practice on which ones have a little bit more meat behind them and having them work.
Okay.
So there's nothing wrong with saying, you know what, Abilify's got a pretty tolerable profile comparatively to everything else out there. That's absolutely right. There's no reason not to use Abilify in the right patient. If somebody has hypomania and, you know, I don't want to look at like lithium or lamotrigine because those tend to have a little, you know, again, more of those recommendations there, that's appropriate. Abilify is fine in the right patient. So I will make sure on the exam those types of things are black and white for
Okay.
you guys to know though. I will specifically key you in to say this patient has never become, you know, manic. She's only been hypomanic and she feels that she's been in good control, you know, and does not want to take something or is opposed to anything that is going to cause her to gain weight. Well, right there, you've got a couple options that fall off, right? So you always have to treat the patient. You never look at it as treating the disease or diagnosis, and you don't want to think about it like that. You want to think about patient symptoms. Bipolar, when I'm in class with you guys, it's a huge spectrum.
Yeah.
Okay, you've got patients that have this as a much more mild disorder all the way up to very severe. So I need to go through the very severe with you, but you have to recognize we're talking about people here. You never want to look at it as, this is your disorder. You want to look at it as, these are the symptoms I've got, and this is the best course of management for it. So, and I know it's harder because that's a little more gray than we normally like to think up until therapeutics, right? You guys can always have a little bit more of that black and white, but I will make sure on the exam I am very, very clear about saying, this is exactly what's going on. You know, you will know what to either rule in or rule out. So, for example, like on the quiz here, we had the female who had epilepsy.
Mm-hmm.
So, if you would have not paid attention to the epilepsy and you looked at the most appropriate mood stabilizer for her, well, lithium probably would be a very good option.
Yeah, that's what I did.
Right? Lithium's a great option until you realize they have epilepsy and it decreases your seizure threshold.
Yeah.
And if you think about your toxicity in lithium, the fact that it causes seizures,
Yeah.
You know, generally you're gonna kind of know that a drug in terms of when it's toxic causes seizures is generally going to be those that decrease seizure threshold.
Right.
So yeah, so that would be a good example. And I just realized too, do you guys want me to go through the bipolar quiz real quick? Yes, okay. So the two quizzes were a lot more similar, so when I go through I shouldn't have to like be looking back and forth as much. So selected true statements regarding bipolar disorder. Most patients who are diagnosed with bipolar 1 initially present with mania or hypomania. That is false. They usually present with depression first, right?
Mm-hmm.
Yep. Okay. There is no clear genetic linkage known in developing bipolar disorder. That is false. We have clearly identified, and the slides in the beginning of the lecture that kind of show exactly that. I mentioned to you guys the TPH2 and the CAC NA1C. Those they have actually, looked at matched controls without bipolar histories in their family even. Not even just they made sure that there is no family history of mood disorders compared to patients that actually, have those types of mood disorders that run in the family, and they have found those genes have a high association. Okay, so there is some clear genetic linkage, and we know first-degree relatives. If you have a first-degree relative that has a mood disorder, whether it's bipolar, whether it's unipolar depression, any type of mood disorder, cyclothymic, any of those, that puts you at a higher risk. So there's some genealogy link there. Suicide is more common when patients are acutely manic than in major depression cycle. So if you look at slide, so we know that it's true with substance use in general, but 30 times greater when depressed, right? If you look at there it is, slide 21. So when you're thinking of suicide, 25 to 50%, attempt suicide, 10 to 15% succeed. They're not exceeding at attempting that, right? And then 30 times greater when depressed. And I went into that STEP B trial where it showed some of the results from that, where one thing that the STEP B trial, I briefly mentioned it in class, but the more engaged in treatment a patient is, which includes just going in, even if you were to do somebody on placebo, the more access to treatment a patient has, the lower the chance they actually have of completing suicide or attempting suicide. And that's one of the things the STEP BD trial did, was that since they were all monitoring them, they noticed their placebo, or not, they didn't do placebo, but the patients that were not having the medication compared to those that did, the fact that they were intervening with actually seeing the patient actually helped decrease the risk. Okay. Hypocalcemia has been attributed to exacerbating a manic episode. So we know hypocalcemia causes mania, hypercalcemia causes depression, right? So
yeah.
We know that calcium replacement calcium replacement has been attributed to being a causative agent. So keep in mind those. So yeah, your hypercalcemia and hypocalcemia can be a problem. So never mind. Okay, here we go. Patients with bipolar 1 and bipolar 2 usually cycle about the same duration of time when in a depressed state. That is false. Bipolar 2 has a longer, more drawn out duration of time in the depressed state, right?
Mm-hmm.
Okay. Questions on that one? You guys good? Okay. So again, we had our 23-year-old female transferred from the med unit, stabilized for a suicide attempt 2 days ago. Past medical history is significant for epilepsy. She's currently still having epileptic issues on a regular basis. Currently diagnosed with bipolar 2 depressed state. She's admitted to being depressed for the past 2 months since she had a miscarriage, tried to commit suicide by overdosing on a prescription of gabapentin and her mother's bottle of OxyContin, diphenhydramine, and drinking a pint of vodka. Her current meds include Neurontin. The psychiatrist has started her on Lexapro and would like to start her on mood stabilizer, but is concerned regarding appropriate therapy due to her seizures. Which of the following would be the most appropriate? So again, you've got lithium ruled out because of the seizures, right? And then if you're looking at most appropriate maintenance mood stabilizer in bipolar 2, you're thinking lithium and lamotrigine. So that's why your answer is lamotrigine. Okay? I didn't trip anybody up there and put something like Seroquel in there because I know that kind of came in as having some good evidence for it as well. Remember your 2 L's, lamotrigine and lithium, and what could rule out from using one or the other. Okay, select a true statement regarding lamotrigine. Dosing too high or titrating the dose up too quickly increases the risk of rash. Is true. Lamotrigine rash affects more adults than pediatrics is false. It affects peds more than it does adults, right? So your kids are at a higher risk on it. If a rash occurs, dosage must be decreased immediately and titrate up slower. That is false. You are never going to give it again. Period.
Right.
Don't ever, ever, ever consider decreasing the dosage and starting it. As soon as you see that rash, they can never have the drug again. Okay? That is a mistake that has been made too often, and the person will end up with Stevens-Johnson syndrome. Okay? That's when you'll see that happen. Yes?
Now, when you're tapering off for the rash, are you going to do that like right away? Or
I'm not giving another dose.
Okay.
As soon as you see that, do not give another dose. Yep. You're cutting it off cold turkey. Now, in an epileptic patient or someone who is stabilized on that dosage, that is going to be a concern because you're going to need to make sure you instantaneously get something on board to prophylax them against a seizure. So stopping any anti-epileptic medication, even if you don't have a seizure disorder, is a bad idea. So I didn't spend a ton of time on this in class, but you would absolutely have to make sure that you kind of put something else on board. That is a situation that I would look at, maybe that rapid titration on a valproic acid, for example, in an epileptic patient, because anything lamotrigine treats, valproic acid does too. It's a broad spectrum anti-epileptic. So for the scope of what I want you guys to know is, you do not give another dose. As soon as you get, that rash, that is signs for a very bad thing. So the risk of giving another dose on the rash to causing the potential risk for Stevens-Johnson syndrome is actually superior to the risk of seizure in that instance. You know that you're going to need to, even in someone who's never had a seizure, because if you're at a high dose and it happens and you stop it, that does, even in a seizure-free patient who's never had one, it could potentially put them at a higher risk. It's not very common that you have somebody that has no seizures, has never had a seizure disorder, and you stop it that would cause a seizure, but it could. So you would need to know, what do I do? I would probably look at seizure precautions, let them know that it could happen. And some doctors would prophylax with valproic acid and taper them down. So I didn't go over that strategy in class. I promise I won't ask a question on that on the exam. You would just need to know they have a rash, stop the drug. Okay? All right. So if a patient misses a few days of medication, a careful titration back to the maintenance dosage is recommended is true. Any dosage increase, just like we talked about in that first one, titrating the dose up too quickly increases the risk of rash. So even if they've been off it we have to do a titration back on it. Okay? And valproic acid is known to increase lamotrigine levels and increase the incidence of rash is true. Valproic acid, you cut your dose in half. Remember the dosing for valproic, the lamotrigine in that instance. Okay? And then let's see, which of the following is true regarding lithium? Blood levels should be drawn 3 days after initiation. When do we draw blood levels?
4 to 5 days.
You usually want to wait 5 days. That's when steady state happens. Okay? That's false. Lithium is known to cause hypothyroidism. That is true. 10 times more likely in women, but can happen in men. You always want to monitor for it. Lithium is known to cause leukopenia as a common side effect. What is leukopenia?
It's decreased.
That is decreased. Leukocytosis, increased, right? So leukocytosis is the common side effect, not leukopenia. That is false. Tremor is seen at therapeutic blood levels. That is true. Remember, even at therapeutic blood levels, I've had some patients even at the lower side will have a coarse tremor. Okay, you usually see that in toxicity, but you can see it at therapeutic blood levels as well. Lithium is less effective in rapid cycling bipolar. That is true. We normally think of carbamazepine and valproic acid as our drugs for our rapid cyclers. Okay, in a patient newly diagnosed with bipolar II disorder, which of the following mood stabilizing medications is the best choice to initiate for maintenance therapy? For bipolar II, best choice, maintenance therapy. So there was risperidol, aripiprazole, lithium, carbamazepine, and nifedipine. So hopefully you guys remember lithium lamictal for bipolar II, right? The answer is lithium. Which of the following has not been attributed to exacerbating a manic episode in bipolar patients? So hypocalcemia, ibuprofen, hypothyroidism, sleep deprivation, and steroid usage. So hyperthyroidism can cause mania, not hypothyroidism. Remember, the difference is, and I tried to make this clear in the case, if you have hypothyroidism and the TSH levels are increased, it increases your risk for having cycles. It doesn't necessarily increase your risk for having mania, though your cycles often are sped up potentially. If it's going to cause more than anything, it's probably going to be depression. We know hypothyroidism, same as when you guys learned it with teeter, same in bipolar, the depressed side. Okay? All right. Which of the following has not been, oh, we thought we did that one. Okay. Lithium can cause many adverse effects. In a patient taking lithium, all of the following laboratory values or tests could be altered, except
ELT.
so we have AST, which is liver. I don't care about the liver enzymes as much when I'm looking at lithium, unless the kidneys fail, and then I'm looking at multi-organ. Okay? If your kidneys are completely shot, you can potentially have the body's immune response start hitting your liver. I didn't go over that in class. You guys will learn that later. Okay? But I am not worried about lithium in the liver enzymes. I'm worried about the kidney and the thyroid and the white blood cells. I'm also worried about it with EKG abnormalities as well, for those of you who took it yesterday. Okay, and for questions 8 through 10, fill in the blank for the following plasma blood levels. So lithium ranges from
0.4 to 1.
0.4 to 1 for maintenance, right? The key to this was maintenance, not acute. Acute is what?
0.8 to 1.2.
0.8 to 1.2. Up to 1.4 in rare situations. I don't like saying 1.4 because we like to limit it at 1.2. You really start seeing side effects at 1 or above a lot more commonly. Okay, so remember that same thing is true for divalproic sodium, right? Valproic acid. So our normal levels we think about are 50 to 100 for maintenance. You can go up to 125 for acute. We've even seen same thing that happens in lithium where it's 1.2 to 1.4. So 125 in acute, up to 150 in acute if the patient isn't having serious side effects.
What was the answer for the valproic acid
So
on
for
that
this,
one?
for maintenance, it's 50 to 100. If you would have put 125 to 150, that is what you see for acute. Okay? Again, above 100 is when you start seeing more side effects. We don't like to see our maintenance above 100. And then carbamazepine,
4 to 12.
4 to 12, exactly, 4 to 12, for acute and maintenance. same range.